Next call upon Dr. Manisha AGARWAL for her talk on imaging in diagnosis and management of diabetic retinopathy.
Dr. Manisha AGARWAL is currently the General Secretary of the Vitreoretina Society of India.
Good morning, everyone, and thank you, Dr. Piyush and Dr. Taraprasad Dasa, for making me a part of this wonderful National Symposium on Diabetic Retinopathy. So, imaging modalities in DR are of significant utility, not only in the management, but also in the screening, evaluation, and diagnosing diabetic retinopathy. There are various imaging techniques that can be useful depending upon the manifestation of DR that you are dealing with. It could be right from a simple color fundus photograph to more complicated investigations like fundus fluorescein angiography, OCT, and OCTA. A simple color fundus photograph is extremely important when you want to screen a patient for diabetic retinopathy, and it's also important to do a documentation of what stage of DR you are dealing with so that you can properly counsel the patient for further management. It is also useful for monitoring the progression of DR, and there are various types of fundus photographs which are available in today's time. Fundus photograph again can be very useful, and it can be used for screening patients in non-ophthalmic clinics using either a non-mydriatic fundus camera, which are AI based, or by using telemedicine, as was very beautifully shown by Dr. Kim. The advantages being that it has an easier access, better compliance, as these screenings can be done at primary healthcare provider clinics themselves without really having the patient to specially come to ophthalmic clinics for just the purpose of screening for DR. If you use a telemedicine unit or a model, then the turnaround time is about 1 hour. And if we are using an AI-based non-mydriatic fundus camera, then the turnaround time is as short as 1 minute. Coming to fundus fluorescein angiography, we have to remember it's an invasive procedure, so it cannot be taken lightly. However, it still remains the gold standard for management of DR. There are various indications for performing an invasive procedure like FFA, which does have a potential risk of various complications. So we have to know when to really indicate a patient to undergo an FFA. But the importance is that in today's time, we have wide field angiograms, and they are revealing much more information about the peripheral changes of DR rather than the typical ETDRS field that we were using initially. A wide field FFA can also play a very important role in planning the management, and when you have patients with persistent neovascularization of the retina and you do a wide field FFA, you are actually able to identify the peripheral areas of the retina which require more laser photocoagulation because of the persistence of the capillary non-perfusion areas, leading to the persistence of neovascularization of the retina. Coming to OCT, we know it's a non-invasive test. It does a quantitative assessment of DME, and there are various types of DMEs which have been described. We can also monitor the response to treatment, and also the recurrence of edema can be very well identified. We are also talking of various OCT biomarkers for DME, and these are very helpful when we are planning the management, such as in the first case, you see a thick epiretinal membrane which requires a surgical management and is going to actually deteriorate if we try to give anti-VEGF injections in such a patient. A patient with neurosensory detachment is an indication that this patient is going to respond better to steroids rather than anti-VEGFs. And then the patients who are having degenerative changes like drill and roll are the ones who are not really going to visually benefit on continuing treatment with anti-VEGFs. Coming to OCTA as a non-invasive tool, and it is used both for qualitative and quantitative assessment of macula, including ischemia. There are various angiographic features which you can very well pick up on an OCTA. The various OCTA metrics used for a DR patient are the vessel density, the FAS area, and the area of non-perfusion, and they all help to monitor the progression of diabetic retinopathy. There are various features, again, like you have the microaneurysms, which can be found at various layers on doing an OCTA, though still we know that a FFA is going to be far better in picking up the microaneurysms. You can also pick up other features like an IRMA, The hard exudates, they can all be very well appreciated on doing an OCTA. OCTA can also image the neovascularization of the retina very nicely. And if anybody wants to really know what is going to be the advantage or disadvantage of doing an OCTA over an FFA, well, the advantage is you can pick up very subtle NVEs. The precise measurement and monitoring of the size of NVE is possible, which is obscured due to the leakage on FFA. However, the disadvantage is that the focus depth range of OCTs limits the visualization of highly elevated NVEs beyond the margin of the ILM, which may appear as a shadow rather than the flow. A manual identification of NVE may be more significant. Now, this is a photograph, a color fundus photograph, where you find that you are having these multiple NVs of the retina, and these are very beautifully appreciated on doing an OCTA, adjacent to the CNP areas, again detected on an OCTA. However, if you compare OCTA with an FFA, the disadvantage is that you're not really finding the leakage, the active leakage, which is very well identified on the FFA in comparison to an OCTA. So the monitoring the regression of the neovascularization again can be very well monitored by doing OCTA. And here you have an OCTA picture where you have a very active frond which has regressed on doing a laser photocoagulation. And again, the same can be appreciated on doing an FFA, which shows a florid leakage and shows minimal leakage after the laser photocoagulation. Again, the NVE, which shows a flow when it is active and which has beautifully regressed on doing laser photocoagulation. Macular ischemia again can be picked up by the enlargement of the FAZ, and this again can help you to grade the kind of DR that you are dealing with. The importance of OCTA is also in the recognition of subclinical DR, which has not been possible with any other imaging modality, and changes such as a decrease in the deep plexus vessel density, enlargement of the FAZ, decrease in the parafoveal vessel density both in superficial and deep vascular layers, and impairment of the choriocapillaris can actually detect a subclinical DR even before our eyes can pick up the changes of DR on clinical examination. We now also have a wide field OCTA, which is going to be very useful in picking up these changes in the peripheral retina. Coming to future in diagnosis of DR, the integration of ultra-wide field color fundus photography, OCTA, the omic and the other biomarker research, the artificial intelligence and statistical modeling, they all together are likely to facilitate new DR classifications even before we have clinically manifesting signs of DR on clinical examination. And this is going to help in personalized care for DR management. Therefore, to conclude, color fundus photograph helps in screening for DR even outside the ophthalmic clinics using teleophthalmology and AI-based cameras. Multimodal imaging, including FFA, OCT, and OCTA, help in evaluation, prognostication, and management of DR. Wide field imaging may help in identifying the peripheral retinal changes and early diagnosis of DR. And OCTA may be very helpful to pick up subclinical DR, which has not been possible till today. So thank you so much for patient listening.
Thank you, Manisha. The new idea is emerging in this country can you self-image your retina and then decide when to go or not to go to a physician or ophthalmologist. The idea comes from your clinical thermometer. Now you measure your temperature, you say up to 99, I will tolerate, up to 99.6, I will take a dolo, crosses 100, I'll go to a doctor, etc., etc. So that is not yet completely ready because it requires one imaging system which can diagnose an undilated people properly. Current available anywhere in the world, including India, is not 30% failure. And then the two should be cheap enough to buy. Right. Just like buy a glucometer at home, you can measure own diabetes, own blood pressure. So this is actually good idea. I will encourage that idea. So suppose you all encourage our companies to make the phone or camera smart enough, cheap enough to take a photograph, and then do an AI on that, diagnose in a traffic color of a green, don't go yellow, think about going yellow, red, definitely go. Most of all, this will also another way of solving our problem because the Indian diabetic population is more than the entire UK population. Think about it, what problem we have got.